I give the call to the member for Kooyong.
Thank you very much, Deputy Speaker. This bill proposes amendments to improve enforcement of several integrity measures for Medicare, some minor amendments to the Therapeutic Goods Act of 1989, and amendments related to the government's tobacco and vaping reforms. I'd like to speak to the changes to the Therapeutic Goods Act of 1989, which the government hopes will enhance its capacity to manage and alleviate the consequences of therapeutics goods shortages in Australia. Deputy Speaker, medication shortages have been a significant and ongoing issue in this country for a number of years. I have drawn attention to this issue in question time on several occasions and in questions on notice to the Minister. The fact is that we lack appropriate mechanisms in this country for anticipating or dealing appropriately with medication shortages. Today, the TGA lists 416 medication shortages and 67 anticipated shortages on its website. It receives an average of 120 notifications of new medical shortages every month, at least 10% of which are critical. Last year, we had a national shortage of intravenous fluids for months. This was a shortage which the Health Minister himself admitted he did not see coming. It was a shortage which necessitated postponement of hundreds of elective surgeries and which prolonged inpatient stays in hospitals around Australia. Now, medication shortages are a global problem. The WHO recently reported 300 essential drugs in shortage worldwide. This long-standing problem was exacerbated by the COVID-19 pandemic, sequelae of which included increased production costs and increasingly complex logistic challenges. But these issues are and remain compounded by a lack of Australian domestic manufacturers. More than 90% of the medications that we prescribe in this country are imported, most commonly from India and from China. There is already an existing mechanism in the Therapeutics Goods Act to allow the Secretary of the Department to approve the importation or supply of substitutable unapproved products from overseas, where the Secretary is satisfied that the approved medicine, biological or medical device is unavailable, is already unavailable, or is already in short supply. The amendment before the House today gives similar powers to the Secretary where there is an anticipated shortage of these registered goods. But it's important to note that substitutable overseas goods are often in limited supply overseas, and they are often the subject of significant competition between countries which are seeking to secure supplies for their citizens. So this amendment will enable the Secretary to try and secure ongoing supplies of necessary medications for Australians ahead of time, before we get to the situation where the medications are already in short supply. The fact is, Deputy Speaker, that the government lacks a comprehensive strategy addressing these medication shortages and how to manage them better when they do occur. We have a Medicines Supply Secure Guarantee. It was launched in July 2023, and it requires manufacturers to hold at least 4 to 6 months of key medications in Australia. However, it's not being enforced. All we are being given with this legislation is a minimal increase in our degree of preparedness for what we seem to be accepting is an inevitable occurrence. It's just not good enough. There are clearly no easy answers to this issue, but there are a number of things which the government could do and yet has not yet done to address the problem. A recent report, Understanding the Impact of Medicine Shortages in Australia, found that many Australian patients have to wait a month or more to purchase medicines which are in shortage, or they end up having to buy a second medication. As a result of that, 20% of Australians ration their medicines to make them last longer. Clearly, this can result in adverse outcomes for patients. 14% of patients who try to find a medication and can't find it end up not buying it at all. 4% purchase a non-prescription medicine, and 2% of them end up in hospital. I'll repeat that. 1 in 50 Australians affected by medication shortages ends up in our hospital system. These shortages and discontinuations disproportionately impact certain population groups, including First Nations people and Australians living in rural and regional settings. We know that Australians with a higher incidence of chronic and complex diseases are those who are more likely to require specialist care. They are more vulnerable to shortages and to discontinuations. They may also have diminished capacity to advocate for alternative scripts, to find remaining supplies of medications and to source them privately. Medication shortages don't just cause inconvenience. For doctors, they result in a need for extra consultations, for identifying alternative management options, for writing additional or new scripts, for educating patients about the new medications and providing those patients with psychological support around the change, for organising collection or dispensation of new pharmacotherapies, and for calling pharmacies or the TGA for more information. These activities are made more time-consuming where physicians are unfamiliar with alternative preparations, or when those new agents require either authority scripts or access via the Special Access Scheme, the paperwork for which is considerable. For patients and for pharmacists, uneven and inadequate distribution of medicines is a health equity problem. Delays to accessing or inability to access the best possible medication affects patients negatively. Withdrawal from medications causes side effects. It affects patients negatively. Changes in medications can well result in inadvertent overdoses or unexpected side effects. Where alternative medications have to be sourced, that increases the workload of pharmacists. Patients often experience the extra cost associated with these new drugs, but they also have to pay to go back and see their GP when they have to go back and get a second prescription because they can't access the first-choice medication. The medications affected are often those which are in common use. Medications for ADHD, antibiotics, hormone replacement therapy, transdermal patches have been in chronic supply for some years. Deputy Speaker, I have explained to the Health Minister on a number of occasions that it is a very brave man who gets between a menopausal woman and her HRT. And yet the TGA has advised doctors now to limit starting new patients on HRT patches, accepting that this will help preserve available supplies for those people who are already on them. This is what our health system is reduced to. Similarly, copper IUDs have been in critical shortages for months at a time. Patients have had to arrange themselves to get them delivered from interstate. The HIV prevention drug, PrEP, in shortages for long periods. We have people at risk of developing HIV because we are not providing them with the medications that they need. Last year, there were persistent shortages of the diabetes medication Mounjaro. The long-term national shortage of semaglutide is likely to persist until at least the 31st of December of this year, and that is impacting patients with type 2 diabetes across this country. Finding it and accessing semaglutide or Ozempic has been described as being like winning the lottery. I've also heard from a constituent in Kooyong about their anxiety and fear relating to the shortage of cholestyramine powder sachets. These are used as a last-line therapy for people who have undergone an ileal resection and are at risk of severe diarrhoea related to that. There are very limited alternatives for people with that condition. We have a duty to guarantee Australians, vulnerable Australians, appropriate treatment for their serious medical conditions. At the same time, the recent discontinuation of lomustine capsules sparked a lot of concern in the Australian oncology community. There are very limited alternatives for treatment of glioblastoma, a rare and aggressive form of brain cancer. Taking away one of those alternatives just causes incredible distress to vulnerable Australians. But worst of all, Deputy Speaker, I want to draw the Parliament's attention to the ongoing critical shortages of medications for palliative care in this country. Liquid morphine has been in shortage for months. I'll give you a few examples of the impact of that shortage on constituents from Kooyong. These are examples provided by my constituents. An 88-year-old gentleman who had prostate cancer. He was on oral liquid morphine for breathlessness due to his metastatic disease. He was unable to source that medication in the community. He had to go to the emergency department with uncontrolled breathlessness. He was admitted to hospital, where he died. A 56-year-old woman with metastatic lung cancer, stable on long-acting hydromorphone for pain, who was forced to change to methadone because the hydromorphone was no longer available. She required a 2-week hospital admission to titrate her medications to safety. An 85-year-old man with metastatic bowel cancer, admitted to hospital for 3 weeks due to the need for slow titration onto methadone in lieu of long-acting hydromorphone. a 73-year-old man with end-stage cardiac disease who had to attend a hospital palliative care clinic in person for the ongoing prescription and supply of his MS content granules because he was unable to source them in the community. Deputy Speaker, communication around medication shortages is often poor. Many GPs find out that medications are in shortage from their patients. The frustration relating to medication shortages reduces consumer credibility and trust in healthcare professionals. Many have reported higher rates of physical and verbal abuse when their patients are unable to source the medications that they need. GPs would benefit from collaborative efforts from the TGA with medication suppliers and practice management software producers who could together relatively easily provide online in-practice management software advice regarding discontinuations and supply of the medications that the GPs are prescribing. But the government has not as yet made an effort to put that in place. Pharmacists know when medications are in short supply in their own facilities, but they don't know which nearby stores will have the medication that might be able to help them. And they tell me that they spend hours sometimes calling out to try and help their patients. Some time ago, I suggested to the government that it looked to establishing a central information point for pharmacists so that they can know what medications are in supply in what sites, so that they can save themselves time. Now, clearly there are some commercial sensitivities around knowing which pharmacies have what medications, but we could get around these. As far as I know, there has been no progress on this issue from the government to date. So the legislation in front of the House addresses one part of one aspect of an issue, but it doesn't get to the underlying problem, which is the persisting deficits in the supply chain for many medications in this country, the lack of transparency around their shortages for consumers, doctors and pharmacists, and the inconvenience, the expense and the harm which results from those shortages. We need a better process to identify impending shortages of medications, biologics and devices. Doctors and pharmacists need to know about these shortages and discontinuations sooner. They need greater transparency about the reasons for medication shortages and consistent location-specific information about stock availability. I'm particularly concerned by the cost of the medication shortages for consumers. The fact that Australians often have to pay more for a second or third line agent. And so I call on the government to act on this issue, to develop effective stockpiles of critical medicines, to mandate that medication manufacturers advise the TGA of shortages well in advance, to ensure that we have duplication of registration by the TGA for those medicines which are critical to public health and safety, for the federal government to act to use future Made in Australia or other funding to invest incentives for development of a domestic manufacturing industry for critical medicines, for the government to introduce taxation or fiscal incentives to ensure supply of critical medications which might not otherwise be financially viable to introduce into the small Australian market, and to review the system of statutory price reductions for older medications so as to temper the price reductions that often lead to PBS delisting, to simplify the special access scheme for unapproved medicines and therapeutic goods, and to enhance the regulatory powers of the TGA, to enable it to redistribute scarce medicines to priority patient groups who are at risk of poorer health outcomes. Deputy Speaker, Assistant Minister, we have to do better to protect vulnerable Australians and to ensure that they receive the very best practice care in our country. At the very least, as a show of good faith, in the face of our apparent inability to guarantee access to the optimal medications for these patients' conditions, we have to ensure that Australian patients don't have to pay more to receive lesser medical care.
Thank the member.